Hi class, Professor Alabozic. Next part of our content is oncology. So we just got done with exam 2. So I think you will like this. There's a lot of content to cover. So that's why I think this voiceover will be pretty helpful for you so you can look back on things that we have discussed even outside of the slides. So we'll get going here. So first of all, we just got to talk about what is cancer. So we just get a base of the knowledge of how it forms, where it begins, and what it is. So really considerable progress is being made in the U.S., controlling cancer, but we have a long way to go. It is declining in mortality rates, but still, some of the cancers, especially lung cancer, and cancer of the colon is kind of still up there. So we have a long way to go, but we are making progress. So cancer is a group of diseases that can cause almost any sign or symptom, really. So it's kind of hard to pinpoint cancer right off the bat. But depending on where it's located, sometimes, it's easy to simplify where the location may be. So the signs and symptoms will depend on the location, how big it is, how much it affects the organs or tissues, if it has spread anywhere, or if it, the other term for that is metastasized. So you'll be hearing that a lot along of our PowerPoint slides. Signs and symptoms may appear in different parts of the body, especially with metastasis or spreading. Sometimes cancer starts in places where it won't cause any signs and symptoms until, unfortunately, it's a little bit too late or it has grown quite large. Some cancers are like that, especially, I'm sure you've heard of pancreatic cancer, and sometimes lung cancer can be caught more in the later stages, and that's when the symptoms usually appear. So cancer, it's uncontrolled and unregulated growth of cells. It is the second most common cause of death in the U.S., and the incidence is higher in men than women. And many of these cancers that we're going to go through, you'll see that men tend to have more higher incidences than women. So talking about cancer development, there's two things I want to talk about. So there's two dysfunctions. So we're not going to get too much into cancer development, but I do want you to know two things here. There's defective cell proliferation and there's defective cell differentiation. So we're going to go through both of those. So talking about cell proliferation, it's really the start of a cell. So it's cell growth. It's pretty much the same term. So cell growth, cell proliferation, and that growth begins in the stem cell. So normally, cell growth only begins when there is a cell death or when the body needs new cells. So a good example of when the body needs new cells is if we're having an infection. So the body wants to recreate a lot of white blood cells to fight off whatever the body's fighting. So that's an example of why the body would need new cells. Other than that, it'll create new cells when there's cell death. Also, when we talk about normal cells, they actually respect boundaries of other cells. So they don't grow into each other, they don't bump into each other. There's no invading space. So that's called contact inhibition. So when we talk about cancer cells, the mutation of the cell actually develops during initiation of cell growth, so during cell proliferation. So whatever mutation is going on and whatever happened to the patient is changing the DNA sequence, and that causes the mutation, and that begins right from the start of the cell. And if we're talking about contact inhibition and normal cells respect boundaries, cancer cells do not. So they have a loss of contact inhibition. They're bad neighbors. They bump into each other. They don't respect their boundaries, and they actually build up on top of each other and create clumping. So that's the defective cell proliferation stage. So then we're going to go on to defective cell differentiation. So that's the second dysfunction. So typically this is an orderly process when the cell goes from a state of immaturity to maturity. So if you think about it, a cell's growing up. So they're becoming, young, they're immature, and then they're growing to a mature state. In normal conditions, the differentiated cell is stable and it doesn't change back to its state. So it doesn't go back to its childlike behaviors, if you can think of that. So in cancer cells, they do just the opposite. So instead of maintaining maturity, they pop back into an immature state. So these cells de-differentiate. Okay, instead of differentiate, they de-differentiate, and they return to their previous immature state. So this picture here is, I like this picture here. It shows like a normal cell. So this is kind of proliferation here. So that normal cell is red, and then some mutation happens, DNA changes, and it turns into a cancer cell. And as you can see, they start to proliferate in the wrong way. So remember that contact inhibition? They grow right next to each other. There's no respect for boundaries, and they double up, they triple up, they quadruple up. And here's a good example of how contact inhibition happens is this last picture here. It looks like huge giant clumps of a bunch of cancer cells. So there's contact inhibition, and I'm sure they have de-differentiated and moved back to their immature state. So those are the two types of things I want you to concentrate on: defective cell differentiation and defective cell proliferation. Okay? And we're going to move on a little bit more. We're going to talk a little bit about mutation. So this is when changes originally happen, right? On proliferation, when there's a new cell growth, this is when mutation happens. DNA changes. Sometimes it's inherited from a parent. So that's hereditary, and it's in the body system already. It's within the DNA. It's just when that mutation happens. Or it's acquired during a person's lifetime. So that's the most common. So we talk about some things that cause mutations. So they can be chemical. So examples of chemical can be like arsenic, formaldehyde. If you can, we'll try to think of a few others in class. There's radiation, especially if we think about Hiroshima and the atomic bomb explosion. There's been high incidences of leukemia, also thyroid cancer and bone cancer, and related to the radiation. So that's a type of mutation. Also think about UV radiation. So, rays from the sun, or even, the tanning booths. That's linked to skin cancer and melanoma. Also viral carcinogens. So think of Epstein-Barr virus. That's associated with lymphoma. HIV virus. That's related to Kaposi sarcoma. And then the human papillomavirus, HPV, is related to cervical and anal cancer. So those are all good examples of viral carcinogens. Okay. The next slide is pretty interesting. So I just want to talk about the American Cancer Society warning signs. So these are the updated 2020 warning signs from American Cancer Society. So we'll go through these. So the first one's unexplained weight loss. So typically that's about 10 pounds or more. And then they talk about fever. So fever can be common with cancer, but most often it can happen after cancer has spread or metastasized from where it started. So it can be typically a later sign. Other cancers, it's more an earlier sign. So if we talk about leukemia, fever tends to happen earlier in leukemia. Also fatigue, that can be common, and pain. So pain can be an early symptom for some cancers like bone cancer or testicular cancer. But then again, on the other hand, pain can also be a later sign. So this is when maybe the tumor has enlarged quite a bit, where it's pressing on an organ or some type of tissue, and it's causing an obstruction and causing pain. Sometimes if we talk about a headache that doesn't go away or that doesn't get better with treatment, that could possibly be a symptom of a brain tumor. Talking about back pain, that can be a symptom of cancer of the colon, or rectum, ovaries, and even lung cancer. Pain can often, like I said, be a later sign. Often it has metastasized and spread, and that's usually when the patient can have the symptom of pain. Skin changes. So this is typically more with skin cancer. So we need to look at any recent changes in a mole, a wart, even new lesions that are coming up on the skin, especially for patients who are more fair-skinned. They have freckles, blonde hair, blue eyes. They're typically more predisposed to skin cancer. And also the different colors of the skin too. So darkening of the skin. That could be hyperpigmentation. Yellowing of the skin, that can be jaundice, so something may be going on with the liver. Reddened skin can show erythema. Itching or excessive hair growth. We also want to talk about change in bowel habits or bladder function. Again, that can be colon cancer or bladder cancer. Sores that don't heal. So you might see a lot of sores in the patient's mouth, white patches in the mouth. That could be from possible throat cancer, cancer of the mouth. Unusual bleeding or discharge. Really with the unusual bleeding, that's more in relation to leukemia. A thickening or lump in the breast or other part of the body. We typically, really urge women to check their breasts, check for any lumps for breast cancer. And women are not left out. The men also can get breast cancer. So, men and women should be checking for lumps in the breast. Indigestion or trouble swallowing is also a warning sign, as well as nagging cough or hoarseness, and that is in more relation to lung cancer. Okay, so now we're going to get into our types of cancers. So the first one we're going to talk about is our brain tumors. So about 23,400 people are diagnosed with brain tumors each year in the U.S. The brain is a frequent site for metastasis. So oftentimes patients with like lung cancer, breast cancer, typically it metastasizes to the brain. Most often, the brain tumors occur in middle-aged people, but they can be seen at any age. Meningiomas, which we will get to, that's the most common primary tumor. When I say primary, I mean that it does arise right in the tissue of the brain. It hasn't metastasized. Other common types of tumors are gliomas. So tumors of the brain can occur in any part of the brain or spinal cord. Like I said, primary tumors arise from the tissue of the brain, and then secondary tumors actually result from metastasis, and that's the most common. More than half of brain tumors are malignant, so they infiltrate the brain tissue, and a lot of them aren't able to be surgically removed. Sometimes more of the benign tumors can be removed, but sometimes they can't. So it all depends on the location of the brain, where the tumor is located. Is there going to be more harm done than good if they do operate on the brain? So sometimes complete surgical removal is not feasible. At least sometimes they can take a partial tumor out, so it will relieve some pressure in the brain. Other times we can do radiation and chemo, which can shrink the size of the tumor and alleviate some of the patient's symptoms. So we're going to talk a little bit about different types of brain tumors, and only the ones that I mentioned I would like you to know. We're not going to get too deep into them, just if they're benign, if they're metastasized, or if they're malignant. So the first one we're going to talk about is gliomas. It's a primitive stem cell from the glioblast. So it's highly malignant and very invasive, and it's one of the most devastating tumors of a primary brain tumor. So it originates within the brain. There's a high mortality rate with this type of brain tumor. Then there's the meningioma or meninges. So it can be benign or malignant, but most are benign. Then there's the pituitary gland, pituitary adenomas. So these are usually benign. Then there's the schwannomas, and these are from cells that form myelin sheath around the nerves. It often affects the cranial nerve 8 And if you remember a little bit about cranial nerves, cranial nerve 8 affects auditory and equilibrium, so kind of balance. These tend to be benign or low grade. Then we have the primitive neuroectodermal tumors. These are highly malignant and invasive. They usually metastasize to the spinal cord. And that's really the ones in the pictures that I would like you to know. I'm going to go over a few others that I want you to know that aren't pictured in the slide. There's the astrocytoma, and these are made of glial cells and astrocytes. These are typically low grade to moderate grade. There's the ependyoma, and this is made from the ependymal epithelium. They're typically benign to highly malignant, but most are benign and encapsulated. Oligodendroglioma, that's a big word. So these are made from oligodendrocytes. They're benign and encapsulated. And then there's the hemangioblastomas. And these are made, these are from blood vessels in the brain. They're very rare and benign. This slide shows us a general overview of signs and symptoms of brain tumors. So typically patients will get headaches, seizure activity. There can be changes in personality as well as memory loss, mood swings, loss of balance, fatigue, anxiety or depression, and difficulty concentrating. There can be confusion and disorientation. Patients can also develop vision problems. Some will have difficulty communicating, tingling or stiffness on one side of the body, and nausea. So these depend greatly on location in the brain, but these are just an overall symptoms of brain tumors. And this is what I want you to pay a little bit more attention to. It goes over, the parts of the brain. So we have the parietal lobe, the frontal lobe, brainstem, temporal lobe, cerebellum, occipital lobe. So depending on where the tumor is located is what will affect the patient most, of how the brain works. So if we look at brainstem tumors, the patient will typically have, headaches, drowsiness, vomiting, impaired gait, hearing loss, and sometimes crossed eyes can be a symptom. And if we look at the cerebral hemispheres, so if there is a tumor in either of the hemispheres, it'll depend on, if it's the right cerebral hemisphere, they might have more loss of control on the left side, and vice versa. If it's in the left hemisphere, they'll have more trouble on the right side. So it almost operates if you think of a stroke that happens on the right, you get more defects on the left, and vice versa. Also in cerebral hemisphere tumors, the patient may have ringing in the ears, vertigo, and deafness. Frontal lobe. So the frontal lobe, it controls our thinking, our problem solving, our emotions, and personality. So if there's a tumor there, they may have seizures, they can have some memory loss, personality changes, judgment changes, confusion, visual changes on one or both sides. And then the parietal lobe. So this lobe processes information from the senses. So they may have speech problems, they may have inability to write, and have some spatial disorder. Occipital lobe. This processes visual information. So they'll have vision changes and they can have some seizures. Temporal lobe controls the memory, understanding, and language. There are very few symptoms with the temporal lobe, but they can have hallucinations and seizures. Some may develop auras, visual auras. And then the cerebellum. That is in control of coordination and movement and balance. So if you have a tumor here, the patient can have changes in coordination and gait, also headache and nausea. Also meningeal areas. So if there's a tumor, there can be compression in the meninges, and it depends on the tumor location. So what makes it easier, if you can remember the different parts of the brain and how they operate the body, And if there's a tumor in that part of the brain, those are the symptoms of what's going to be affected. I just want to talk a little bit about increased ICP, intracranial pressure, and also midline shift. So there's a nice short little video on increased ICP, and we'll watch that in class. But a tumor can really put a lot of pressure on the brain, especially if it's larger, and it will increase the ICP. So when there's pressure inside a person's skull, which means the tumor is pressing on the brain, causing more pressure on the skull, it's going to increase the pressure of the brain. So many patients can develop a headache, confusion, nausea, decreased alertness. A midline shift is even worse. So this is pictured here in the slide. So what that arrow is pointing to is actually a tumor that's pushing the brain. And if anyone can notice here right down the middle, it should be that fissure that separates the right and left hemispheres. This left hemisphere of the brain is pushing on over into the right. That is not good at all. That's an emergency. So it's a shift of the brain past its center line. So patients can develop, pupillary changes, dilation of pupils, headache, drowsiness, loss of reflexes. And normal ICP is usually 5 to 15 millimeters of mercury. So anything above 5 to 15 is a problem. I'm not sure if you've heard of mannitol before. It's a medication. It's actually a type of diuretic. It's given to a lot of patients who may have brain tumors or brain trauma that has swelling in the brain. It's actually a diuretic for the brain, and it can decrease the swelling of the brain. So that's a medication that can be given as well. So diagnostics for brain tumors. So an H&P, really important, history and physical. Physical exam. It's a physical exam is really important in respect to the location of the tumor, especially we can look at cranial nerves and see which ones are affected, and see, is it vision, is it balance, is it hearing, and then we can pinpoint a little bit better the location of the tumor. MRI scans are very typical. PET scans, that also stands for positron emission tomography. PET scans are often done in oncology patients, and it will actually, it lights up the areas of where there is actually cancer in the body. CT scanning, EEGs. This actually looks at brain activity. It can help us rule out seizure activity and when seizures may actually start. Cerebral angiography, and that determines the blood flow to the tumor, and it can further localize the tumor location. Endocrine studies, this is mainly for pituitary tumors, and also computer-guided stereotactic biopsies. So that's a little bit more invasive, and you're going in and taking a little biopsy out of the brain. So now we're going to get a little bit into treatment. So surgical removal is the preferred route. First off, it's really important to identify the tumor type, the location. Is it a metastasized tumor? Is it primary tumor? Do we need to remove it, or do we need to decrease the tumor mass? We need to prevent any increase in ICP or any midline shift. If we can do full removal, that's great. That would be preferred. We may have to just do partial. Anything that can alleviate any symptoms for the patient will be, in best interest of the patient. Full removal is not always possible. The tumor may not be accessible, or it may involve vital parts of the brain that we shouldn't touch. So at least with partial removal, it can decrease swelling, decrease ICP, relieve symptoms that the patient may be having. It can extend survival time a little bit. So that's, preferred is full removal. We can always do partial. And, complications of surgery, we want to look, hemorrhage, infection. Then we're going to talk about a ventricular shunt. So this is actually a catheter. It's placed into the ventricle of the brain. It's a one-way valve, and it actually runs from the ventricle of the brain down into the peritoneal cavity. And what this does is it drains CSF, so cerebrospinal fluid. So when there's a tumor obstructing CSF flow, we need to put that ventricular shunt in to decrease swelling of the brain. Now, do we want to drain CSF fast? Absolutely not. So rapid decompression of CSF can cause total body collapse and weakness. It would be an emergent situation. There can be complications of a shunt. So there can be an infection, and then there can be shunt malfunction. So when there is a malfunction, it means it's not working and it's not draining properly. The patient will have restlessness, decreased level of consciousness, headache, blurred vision, and vomiting. Radiation can be a pre-surgical treatment where it can shrink the tumor a little bit before they do surgery for ease to take out the tumor of the brain. It can also be a follow-up measure as well, so they can implant radiation seeds into the brain. Complications with that can be increased ICP and cerebral edema with radiation. Patients may need corticosteroids to manage symptoms, and also chemotherapy is another treatment option. Next, we're going to talk a little bit about nursing care. So again, a full H&P, really important. We want to do a physical assessment. So we need to get a baseline, a neurological assessment. That's really important because, it's the brain. So we want to assess the brain. What do we want to assess? We want to look at level of consciousness. Are they awake? Are they alert and oriented? What are their motor abilities like? How are their pupils? Do they react? Are they equal on both sides? How's their strength? How's their sensory perception? Do they have balance? Do they have any loss of emotion? Are they confused? How's their judgment? Is it off? Do they seem to be impulsive and depressed? Oftentimes, with these types of symptoms, if the patient does have impulsive behaviors or they're depressed and they're withdrawn, it's really disturbing to the family. So a lot of emotional support is needed for the family. The patient and the family may become distance, and they don't know what's going on. So a lot of education is really important, especially for the family. Safety is a big one, so we want to make sure the patient remains safe, especially if they are impulsive, if they're confused. We don't want them to fall. So take into consideration some safety measures, call bell, bed alarm, make sure they're free of falls. We want to assess and treat pain. That's a big one. So if the patient is having any pain, we want to assess that. Are they having headaches? We want to watch for signs and symptoms of increased ICP. So if the patient has a frontal lobe tumor, what considerations should we take into account? Again, that's with the judgment. That's their perception. That's their thinking. They may be confused. Again, safety is a big one. Seizures, we want to, make sure to administer medications to alleviate any symptoms of seizures. Some examples of those is Dilantin, also known as phenytoin, Trileptal, and Tegretol. Also, what else can we do for seizures? We need to make sure that there's seizure pads on the bed, make sure that there's suction set up in the room. Those would be the main things that we would want for seizure activity. So also care for the surgical patient. What is our priority? So say we got the patient post-op. We would want to, watch for hemorrhaging, watch for signs and symptoms of infection, watch for symptoms of ICP, maintain the sutures, maintain, cleanliness, hand hygiene. How does the skin look like on the skull? encourage nutritional support, and also if there is any language or communication barriers, we want to help with that as well. So now we're moving on to lung cancer. That's it for brain tumors. So lung cancer is a leading cause of cancer-related deaths in the U.S. A lot of advances in medicine are improving mortality rates every day, so we are getting a little bit better. And the big question here, what causes 80 to 90% of lung cancers? I know you guys know this, but this is tobacco products. So tobacco smoke contains over 7,000 chemicals, and at least 250 of them are most harmful to our patients. So these attack normal cell development. Remember we talked about cell proliferation, and that's where mutation of carcinogens happens. So this is where that will happen when new cells form. So it attacks normal cell development and it ends up in mutation. Other common causes are from pollution, radiation exposure, and asbestos. Lung tumors arise from mutated epithelial cells. Lung cancer tends to grow slowly, so it doesn't just happen and you have an onset of symptoms. It takes about 8 to 10 years for a tumor to reach at least the size of 1 centimeter. So it's a slow growing process. Lung cancer can occur in the segmental bronchi and usually in the upper lobes of the lung. So there's two subtypes of lung cancer. There's non-small cell lung cancer, which accounts for 85%, and then there's the small cell lung cancer that is less common and accounts for 15%. So this is just another slide showing the differences between non-small cell lung cancer. Again, 85 to 90%. It's the most common type of lung cancer. It usually arises in the outer region of the lung. It may look like pneumonia on chest x-ray, so patients may present like they're having pneumonia, and it's usually picked up either on CT scan or on the chest x-ray, and this tends to be more common in women. And then there's the small cell lung cancer. This accounts for 10 to 15% of lung cancers. So this is the most aggressive type. It's rapidly growing. It can metastasize easily. So this type of cancer you may see metastasize more to the brain. And it's strongly related to cigarette smoking. So again, non-small cell lung cancer accounts for 85 to 90%. It's most common in those who have not smoked. It's found in the peripheral areas of the lung, so more on the outside region. There's really no manifestations until there's widespread metastasis, so it's kind of dangerous there. So we're catching this at a later stage. So I want to talk a little bit about paraneoplastic syndrome. So lung cancers cause this syndrome. It's caused by hormones, cytokines, and enzymes. These are all secreted by tumor cells, and these tumor cells destroy the healthy cells. So in this syndrome, the patient will have high levels of calcium, hypercalcemia. They'll have the syndrome of inappropriate antidiuretic hormone, also known as SIADH. And this causes the body to retain water instead of excreting it normally within the urine. There's polycythemia. So that is an increase in the number of red blood cells in the body, and it causes the blood to be thicker, which in turn can cause clots. There's also Cushing's syndrome. So that is responsible for high cortisol levels. You'll see patients typically tend to gain a lot of weight. They have a moon face and they gain a lot of weight in the abdominal region. There's also adrenal hypersecretion. So all these symptoms commonly occur before the cancer is even diagnosed. So the patient will have a paraneoplastic syndrome, and this may help with diagnosis of lung cancer. This is mostly associated with small cell lung cancer, and these conditions may stabilize once treatment of the underlying cancer is treated. So symptoms of lung cancer. Typically, the patient presents with a chronic persistent cough. They'll be they'll be short of breath. They can develop wheezing, so you want to definitely listen to their lung sounds. They'll have blood-tinged sputum. They can develop chest pain. You'll notice fatigue, anorexia. They lose their appetite. They'll have nausea and vomiting. They'll have weight loss and develop back pain. Again, like we talked about earlier, usually symptoms appear later in the disease process. And again, symptoms depend on the type and location. Also, if there has been any metastasis. Lung cancer often can present as pneumonia, that does not respond to treatment. So a patient may have recurring pneumonia, but they're just not responding to treatment. It's actually underlying lung cancer. So how do we diagnose lung cancer? Again, H&P, physical exam, those are really important. Back to the basics. An accurate assessment is crucial to the staging of cancer and also diagnosing the type, either non-small cell or small cell. A bronchoscopy can be done. Usually they'll take a biopsy when they go in and do a bronchoscopy. They'll do kind of washing out of the airway, and they can actually take fluid from that space and send it for testing. We can also do fine needle aspiration of the pleural fluid space, and that can also be sent for testing. Chest x-rays, CT scan, MRI. We talked about PET scans, lung tissue biopsy, also sputum studies, a video-assisted thoracoscopic surgery. That's a lot more invasive. It's actually a surgical procedure going into the lungs. That's when they would, if they're doing a diagnostic study, they would take a biopsy of the lung tissue. Also thoracentesis. So that is a needle going into the pleural space, taking out fluid, and that fluid can be tested. So staging of lung cancer. We start off at a 0, and these are when cells are just found in the respiratory airway and alveoli. So nothing has moved out from those areas. Then we go to stage 1. So this is when the tumor is small. It's localized to the lung and there's no lymph node involvement. So the tumor is typically less than 3 centimeters. That would be 1A. And then 1B is when the tumor is 3 to 4 centimeters and it starts invading the main airway. Then we go to stage 2. So this is when the tumor increases in size and there's some lymph node involvement. With 2A, the tumor becomes a size of 4 to 5 centimeters. It starts invading the main airway, the visceral pleura, and the lymph nodes. And then 2B is when the tumor is 5 to 7 centimeters with the same invasion as above. Then we go to stage 3, and this is with increased spread of the tumor. 3A is when the tumor is at least 5 centimeters and it has spread to the chest wall, pleura, and even the pericardium. 3B is again when this tumor is at least 5 centimeters and it starts involving the heart, the trachea, the esophagus, and the mediastinum. And then 3B is when the tumor is again at least 5 centimeters and then it's taking up more than one lobe of the lung. Stage 4 is distant metastasis. So surgical treatment. So pre-procedure, the patient should have, ABGs completed. They should have pulmonary function tests. They should have anesthesia consults and also critical care and pulmonic consults, just to make sure that the patient can tolerate the procedure. They'll be able to recover properly, and it's a big procedure. So it's important to know that the patient can tolerate that. So they can do a surgical resection. That's the treatment of choice for non-small cell lung cancer in stages 1 to 3A. And that's if there's no mediastinal involvement. So surgical resection. We then move on to a segmental resection. So that involves removing a section of the lobe, removing the tumor portion and the tissue around the periphery. And then moving on to a wedge resection. and it's a removal of a small wedge-shaped piece of lung tissue. Then we get to the lobectomy. So this is actually removal of one or more lobes of the lung. We talked a little bit about a VAT, since it's video-assisted thoracotomy. And this is if the tumor is near the outside portion of the lung. Surgery is not done for small cell lung cancer. That's due to its rapid growth, rapid metastasis, high mortality rate. Typically, palliative care is more the treatment option, chemotherapy, radiation, to at least shrink the tumors in the lung. Again, if a patient is having surgery in conjunction, they still can have radiation and chemo to shrink the tumor. And then post-op care. So what do we want to know as nurses? How can we help these patients post-operatively? So a thoracotomy incision is pretty much the most painful surgical incision for patients. They actually cut respiratory muscles, and it makes for intense pain and a really difficult recovery. So we really want to focus on pain management. The patient can receive PCAs, epidurals, intercostal nerve blocks. And why do you think pain management is so important? If we don't properly give the patient pain medication, do you think they're going to breathe properly? They'll ventilate properly? Probably not. They probably don't want to take deep breaths if they're in major pain. But we need them to, because the last thing we need is for them to get pneumonia or any other infection. So we want them to, have pain medication to practice coughing and deep breathing, working on splinting with the patient, working on the incentive spirometer. We also want to monitor their respiratory rate. What's their work of breathing? What's the O2 sats? How do their breath sounds sound? Can we get a sputum sample? Are they coughing up a lot of sputum? What's the color of the sputum? Are they coughing a lot? Is it dry? Also, they're typically a chest tube is placed, and they place that for chest re-expansion and also to get rid of some extra fluid in the lung. So especially doing care of the chest tube. So we want to do a chest tube assessment. Is it hooked up to wall suction? What is the order? Is it to medium continuous wall suction? What's the color of the drainage coming out into the chest tube? How much is there? Is there an air leak? We want to look for all these things in the chest tube. We talked about respiratory assessment. We also want to monitor the surgical site incision, right? Also the chest tube site. So is there drainage on the dressing? How do the sutures look? Is there any signs of infection going on? Aside from surgical procedures, radiation therapy can also be utilized. It can be used for both non-small cell lung cancer and small cell lung cancer, and it can be used as curative or palliative treatment. So it also can be used for primary therapy for patients who cannot tolerate surgical procedures at all. It can help relieve symptoms of the tumor, so it can cut down on the patient's shortness of breath, if they're having any hemoptysis, if they're even having a bronchial obstruction. It can help shrink that mass. Also, if the patient is going for surgery, it can also help shrink the mass a little bit to make the surgery a little bit easier for the surgeon to take out the mass as well. There's also something called stereotactic body radiotherapy. So this is a strong high dose of radiation, and it's used for lung cancer. It uses a special positioning procedure. So the patient has to be specially positioned so that it aims only at the tumor. They try not to get any parts of the lung that's not affected, only the portion that is affected. So they have to be pretty spot on with the positioning of the radiation therapy. So what it does is it damages tumor DNA, and it is given usually over 1 to 3 days. Some complications for any radiation therapy can be esophagitis, so inflammation in the esophagus, skin irritation, some burning on the skin, nausea, vomiting, anorexia, and radiation pneumonitis, which is really inflammation of the lung as well. Chemotherapy tends to be a main treatment for small cell lung cancer just because it's so aggressive and so quickly, it can spread quickly. So it usually consists of a combination of the two of the following: etoposide, carboplatin, cisplatin, paclitaxel, and docetaxel. So that's provider specific, and that will be provider preference depending on what the cancer looks like to the provider. So they'll usually pick two, out of the following five. In non-small cell lung cancer, chemo can be used. It can be used in conjunction with non-resectable lung tumors, or also as adjuvant therapy for surgical procedures. So if the patient is getting a surgical procedure, they can use chemotherapy as well. Nursing care. So really, emotional support is a big one. We talked about, the anxiety level for patients going through cancer diagnosis, especially during the diagnostic time where the patient is so unsure of what's going on. So just a lot of emotional support, making sure we know the patient's goals. Education on smoking cessation. This is definitely the time to really hone in on if the patient is smoking and to make sure that they stop immediately. Providing comfort, and if they're in pain management. Oxygenation, we want to make sure they're oxygenating okay. Do they need O2? If they're having nausea, making sure that we give antianemics or nausea medication for side effects, usually of treatment. Maintaining their nutrition. They go through anorexia, they go through decreased appetite. So whatever we can offer the patient to increase their appetite a little bit will be best. Do they need oxygen at home? Always making sure that they have adequate airway clearance, effective breathing, effective oxygenation, minimal to no discomfort, and also anxiety. Always observing for fever. Always looking actually for edema around the face and neck as well. If a tumor is blocking an airway, we may notice that through edema. So it's really always important to make sure that their airway is patent and clear. And edema, making sure that we cut down on the edema so there's no swelling to the neck. There is something called superior vena cava syndrome, and that is when a tumor is actually partially blocking or compressing the superior vena cava. So that can actually cause increased edema to the airway. Do you notice any digital clubbing on the patient, on their fingers? That can mean that they've had a decreased oxygenation for quite some time. If there's any jaundice, it may be significant for metastasis. So noticing that as well. Making sure we listen for wheezing, stridor. Are they shortness of breath? Are they using accessory muscles? Pleural effusion, which means that there is extra fluid in the lung, is pretty much a later sign of lung cancer. So we want to watch out for those symptoms, which would be fluid overload. It would be shortness of breath. Even dysrhythmias, that is a late sign as well. So now we're going to move on to bladder cancer. And the most frequent cancerous tumor of the bladder is called transitional cell cancer of the bladder. There's also papillomatous growths within the cancer as well. And again, half of bladder cancers are related to smoking. So the most common cancer in the urinary system is bladder cancer. And usually about 81,000 new cases get diagnosed annually in the US. It seems to be most common in older adults and far more common in men than women. Women who tend to get treated with radiation therapy in relation to cervical cancer have a higher incidence to develop bladder cancer. Also, if patients have long-term indwelling caths, they have an increased risk for bladder cancer, or patients who've had continual UTIs or actually stones also have an increased risk for bladder cancer. The symptoms for this, it could be microscopic, gross, painless hematuria. So really visually noticing a pink tinge to a bloody tinge in the urine. It can be chronic or it can be intermittent. The on and off, it would seem more dangerous because it might not be a thing that you could catch or noticeable sometimes. There could be bladder irritability, also with dysuria, frequency and urgency. So they may have continuous symptoms that are similar to UTIs. So it's important to obtain urine specimens and to identify atypical cells. So that can be done right in a UA. So if you get a UA on a patient, there's exfoliated cells that come from the bladder lining, and those could show up for testing in a UA. Also CT scans, ultrasounds can be done, MRIs, and confirmation is usually done by a cystoscopy, and a biopsy is taken of some of the bladder tissue. So this is some staging for bladder cancer. Stage 1 is when cancer is in the inner lining of the bladder, but it has not invaded the bladder muscle wall. Stage 2 is when the cancer has invaded the bladder wall, but it is still confined to the bladder. Stage 3 is when the cancer has spread through the bladder wall to the surrounding tissue. So we have some spreading going on. It could be spread to the prostate in men or the uterus or vagina in women. And then there's stage 4. So this cancer has spread to the lymph nodes, other organs. There's distant metastasis to the lungs, bone, or liver typically. So how can we treat bladder cancer? So here's some surgical treatments that we can do. The most common can be, it's a TURP, or a transurethral resection of the bladder tumor. So this is typically used more for superficial lesions of the bladder in the inner lining. So what this test or procedure does is the provider uses a wire loop. It's inserted through a cystoscope to remove the tumor tissue, and that usually gets sent for testing. And also that base where they took the tumor out, now the lining, they're going to cauterize that lining a little bit where the tumor was. That's also known as fulguration or burning. So they're using high energy laser to kill the remaining cancer cells that may still be living on the inner lining of the bladder. If patients tend to have TURP procedures often, they may develop scar tissue or fibrosed tissue within the bladder. And also there may be a chance for reoccurrence. So just something to think about with TURP procedures. And also if patients do have repeated procedures, there may be limited ability to hold urine after some time. There's also segmental cystectomy. So this is just taking a portion of the bladder out. This is used to treat larger tumors of the bladder that only involve one area of the bladder. Okay, so they don't have to take the whole bladder. They just take a section of it. And then something a little bit more invasive is the radical cystectomy. So this is actually removal of the bladder, prostate, and seminal vesicles in men. And then in women, they take the bladder, urethra, uterus, cervix, and interior vagina. So great portions of the urinary tract. So if a patient does have a radical cystectomy, they will need a urinary diversion and a new way to eliminate urine. This is just showing us an example of how they may place a urinary diversion. So on the left, it looks like they have, this is called the neobladder. So they have taken a good portion of the bladder. And then what they do is they create a stoma to the outside of the body. And usually a bag will be attached to the stoma. It's very similar to a colostomy bag, but just for urine. So nursing care as well as post-op care. We always talk about that emotional support and anxiety. That's huge for cancer patients. It's really important to push IV fluids or PO liquids if they can tolerate that, especially for the first week post-op. Again, very similar to what we talked about kidney stones. We don't want to really flush the system with fluids or push the fluids really fast. That could lead to more colicky pain, but just making sure the patient remains hydrated and they're getting that flushing of the system. Always monitor the color and consistency of the patient's urine. The urine should be pink for just a few days after procedure, but it should never be a bright red or contain bright red clots. Pain management. Voiding can be irritable. They can have irritable voiding symptoms and possibly a cystitis post-procedure, so inflammation of the bladder. So making sure that we do consider pain management, of course. Stool softeners. We do not want the patient to be straining at all. We don't want to increase any risk of hemorrhage. There's also special radiation therapy that can be used in conjunction with a cystectomy, or radiation therapy can be used as the primary therapy if the bladder tumor is inoperable. Chemotherapy and immunotherapy can also be used. So what's very common is it's called intravesical therapy. So it's chemo and immunotherapy used together. And what this is it's chemo directly delivered inside of the bladder by a urethral catheter. And usually that's done over a 2-hour period. This is done in intervals 6 to 12 weeks long. It's important for the bladder to be empty before installation, okay, before they put the urethral catheter in that delivers the chemo. It's very important to have the patient empty their bladder or make sure the bladder is empty. With this chemotherapy, it can significantly reduce white blood cells as well as platelet counts. The patient may feel like they're having flu-like symptoms. They may have the symptoms of increased frequency and hematuria, along with nausea, vomiting, and hair loss, which can be typical for chemotherapy. So as nursing, we want to make sure that we help all the side effects and those symptoms of the side effects, anti-anemics, maintaining their nutrition, looking at the urine, watching for hematuria, watching their labs, their white blood cell counts, their platelet counts. And then we're going to move on to colorectal cancer. So that was cancer of the bladder. And now we're going to move on to colon cancer, colorectal cancer. This is the third leading cause of cancer deaths and also the third most common cancer in men and women. And a large amount, 140,000, are diagnosed annually. The risk of this usually increases with age. So 90% of cases are with people older than 50. But the strange thing about this is that that number is actually decreasing for the older adults. And the population age for 20 to 49 years is actually increasing. So it's actually turning around more towards the younger population. And they're figuring that due to obesity changes, diet changes, and inactivity of this current time in our lifestyle. Usually the risk is highest if the patient has had a family history, so first-degree relatives who have had colon cancer or colorectal cancer, you're at a very high risk. So that's really important, why colonoscopies are important, and making sure that you have proper management for colon cancer. Also, patients who have irritable bowel disease you have an increased risk as well. Colorectal cancer usually starts as a polyp in the inner lining of the colon or rectum, and it can grow over a period of 10 to 12 years, so 10 to 20 years, excuse me, so that's quite a long time. Most polyps are adenomas, and those arise from cells that make mucus. And as the tumor grows, the cancer invades and penetrates the wall of the colon or rectum. Eventually, the cancer will gain access to lymph nodes, vascular system, and this is how we get distant metastasis. The liver is a very common site for metastasis of colon cancer. I feel this is a pretty helpful diagram of the staging of colon cancer. So if we're looking at stage 0 here, cancer has not grown beyond the mucosal layer of the colon. So it's within the colon. It hasn't grown into the wall yet. When we go to stage 1, the cancer has grown beyond the mucosal layer into the submucosa, but there's no lymph node involvement. Stage 2 is beyond the submucosa, and it's actually going into the muscle, but still no lymph node involvement or metastasis. Stage 3, we're into the muscle, and now we do have some lymph node involvement, but no metastasis. And then in stage 4, there is lymph node involvement and spread to other organs. So presentation, how do patients present? So colorectal cancer, it's slowly developing, and symptoms usually don't arise until the disease is advanced. So we might see some iron deficiency anemia, especially if the patient isn't bleeding slowly internally. There may be some rectal bleeding, abdominal pain. The patient may have thin ribbon-like stools. They can feel rectal pressure or fullness, change in bowel habits, sometimes even going from diarrhea to constipation, feeling of fatigue, having some weight loss, that abdominal tenderness. A late stage would be a palpable mass as well as ascites, especially if it has spread to the liver. That's where ascites may begin. Bleeding on the right side of the colon is more common than on the left. And right-sided cancers of the colon are more likely to cause diarrhea, where left-sided cancers are detected later. So left-sided is detected at a later stage and usually presents with more of a bowel obstruction rather than diarrhea. Complications of colorectal cancer usually lead to obstruction, bleeding, perforation. Patient can have peritonitis, as well as fistula formation. And diagnostics, how can we diagnose a patient with colorectal cancer? So like I say, with every disease process, history and physical is so important. Getting that family history, because it's so hereditary, we need to know the family history. Really put an emphasis on screening, especially if you've had family members, first-degree relatives, who've had a history of colorectal cancer. We really need to get the patient screened at an earlier age. Typically, we start screening patients at age 45, but if there has been a history, we want to do that earlier, and that will be provider preference. What is typical is usually a flexible sigmoidoscopy is done every 5 years with a biopsy, and a colonoscopy is done every 10 years. Again, that might be more frequent with patients who've had a family history. We can do a digital rectal exam, or the provider would, just to see if there is frank blood within the rectum. Testing for occult blood in the stool. Looking at the CBC, is the patient anemic? Looking at the liver function tests, CT scan, MRIs, ultrasounds, PET scans. So once a diagnosis is made, we typically talk about surgical therapy. We want to get that tumor out. So complete resection of the tumor, usually done through an exploratory lab. Exploration of the abdomen is frequently used. It's also used to determine if there's any metastasis. We want to remove any lymph nodes, that drain the area where the cancer is located. And we always want to make sure that we can restore bowel functions if we can. So just a polypectomy, probably the least invasive. This can actually be done during a colonoscopy. The polyps are taken out and they can be sent for cytology testing. Then we talk about laparoscopic surgery. This is usually done with removing more of the stage 1 cancer, and it includes removing the tumor within the colon and at least 5 centimeters of the intestine on either side, as well as any surrounding lymph nodes. The remaining intestine on either side is sewn back together. That's called the anastomosis. So you're taking the 2 new ends of the intestine and combining that to sew the intestines together. Stage 2 tumors are, normally treated with a wide resection with a reanastomosis. Chemotherapy is typically used in conjunction with surgery when the tumor is not able to be resected, or even during palliative care treatment. Chemo can be used, and what that can do is just decrease the symptoms that the patient may be having. It can be used to prevent any hemorrhage or relieve any bowel obstructions just by relieving some of the size of the tumor for the patient. Stage 3 tumors are usually treated in conjunction with both surgery and chemo, as well as chemo and radiation can be done before a surgical procedure to shrink that tumor a little bit. So it's better ease for the surgeon to go in and take out the tumor. And it might be better for the colon as well. They may not have to resect as much, so they would pre-treat the patient with chemo and radiation. And this is just an example showing you what an anastomosis may look like. So on the left here, it's showing you the cancer within the colon. This would be the transverse colon. Ascending, transverse, descending to the rectum. They're removing, in the middle picture, they remove the cancer. And of course, like they said, 5 centimeters on either side. And then they're going to sew the new ends together. And that is what an anastomosis is. And then we're talking about a colostomy. So depending on where the tumor is within the colon, especially if it's more towards the rectum or the descending colon, we may need to have a colostomy bag. Normal bowels may not be able to function again. So it's very dependent on the location within the colon. So here on the left, we have cancer, in the descending colon here, almost going to the rectum. They take out the portion of the tumor, and of course, as well as 5 centimeters on either side. And unfortunately, they've had to create a stoma to divert the stool into a bag. Typically, of course, if the colon or the rectum and the sphincters cannot be preserved, the patient may need to undergo that resection and receive a stoma. Sometimes the bags may have to be permanent. Sometimes they don't have to be permanent. So that is, again, all dependent on the location within the colon. They may be temporary, but again, if the sphincters can be preserved, typically the colostomy bag is temporary. So let's talk about some nursing care, post-op care. And like I always say, H&P, history and physical. And during that physical exam, what do we really want to look for in our GI assessment, right? So we want to talk about bowel sounds. We want to see what their bowel habits are. Are they having diarrhea? Are they having constipation? What does their stool look like? What's the color? Is it black? Is it red? Do they have frank blood? Is it old blood? Is it ribbon-like stool? How is their diet? Are they having nausea and vomiting? Have they been losing weight? Is there a palpable mass? Do you see any ascites? If you do get to look at the stool, can you notice any bleeding? Should we guaiac the stool for any blood? How are your feelings of evacuation? Does it feel incomplete after having a bowel movement? Any increased gas? Those are important things to know during the physical assessment. Emotional support, that's a really big one. Encouraging colonoscopy screenings, especially if they've had that family history. Vital signs are really important, especially, we want to look for any signs of bleeding. Ascites is a big one. Assess for any anemia. Make sure to look at the labs, look at the H&H. And especially if we're talking about post-op care, we want to watch for infection, right? Any issues with bleeding or hemorrhage. How does the incision look? How do the sutures look? How's the site? How's the dressing? Is there any is there any drainage on the dressing? Is it sanguinous, serosanguinous? How's the skin color? Is there any drains? Do they have a Jackson-Patt drain, also known as a JP drain, or a hemovac? What's the fluid coming out of there look like? What's the color? How much? If they have an ostomy, are they producing any stool? Usually after an ostomy is created, it takes a little bit for peristalsis to reoccur after a big surgery like that. So typically it is normal for at least a few days, if not more, to not produce any stool within the colostomy bag. What does the stoma look like? How's the color of it? Is it a rose color, brick red, pale? Is it blanching? Is it edematous? Is it a really dark red or purple? Is there bleeding coming out of the ostomy? How's the stool consistency when they do start to make stool? Doing ostomy education too. That's a big one for patients with new ostomies. So that's the end of colon cancer, colorectal cancer. We're going to move on to skin cancer. So this is the most commonly diagnosed cancer. And why do you think that? It's really due to the fact that you can see it. It's not within the body. You can see it on your skin. So it's easily diagnosed and detected, compared to other cancers. So there's skin cancer split up into non-melanoma and melanoma. And again, early detection is due to skin lesions being visible. So the prognosis is usually high. It's good. Some risk factors for skin cancer can be patients who are more fair-skinned. They may have blonde, red hair, blue eyes. If they're outdoors a lot, they do the indoor tanning booths. People who live near the equator, as well as family history. Darker skinned people tend to have less of a risk due to that they have an increased melana within their skin, and that melana acts as a sunscreen. But it definitely does not mean that sunscreen should not be used. It should always be used as a preventative measure, whether you have lighter skin or darker skin. Patients who do have darker skin tend to develop melanomas on their palms, soles of their feet, within their mucous membranes, and even under their nails. So that's something to keep in mind. So we're going to go over non-melanoma first. And these are split up into either basal cell skin cancer or squamous cell skin cancer. Non-melanoma is the most common form of skin cancer. They do not develop from melanoma sites. That would be more on the melanoma side. They actually develop in the basement membrane of the skin. Non-melanomas typically develop in sun-exposed areas. So if you think of the face, the forehead, tops of the ears, the neck, tops of the head, tops of the shoulder, the arms are very common places for non-melanoma skin cancer. So the basal cell skin cancer usually arises from the epidermal basal cells. It is the most common type, but the least deadly. They usually occur in sun-protected areas. So usually what we need for diagnosis is usually just a tissue biopsy. It's needed to confirm diagnosis. It rarely metastasizes, but if it's left untreated, it can cause major tissue destruction. So we need to treat it. We need to surgically remove the basal cell skin cancer. Sometimes it can be treated with radiation and laser therapy as well. Now if we're talking about squamous cell skin cancer, this one arises from keratinizing epidermal cells. It can be more aggressive and it does have the potential to metastasize, so a little bit more deadly. This one can lead to death if not treated. So risk factors are also sun exposure. as well as immunosuppression after organ transplantation. I thought that was pretty interesting. So if a patient is on a drug that helps with immunosuppression after organ transplant, they may be at more risk for squamous cell skin cancer. Tobacco can also contribute to squamous cell. You may see this more around the mouth and the lips. So again, treatment is pretty similar to basal. We'd want to do surgical excision of the tumor. Radiation, laser can be used. And if there is metastasis, we may need to use chemo as well. So melanoma, the most dangerous skin cancer. So the incidence is really steadily rising. So we need to really do a lot of education with staying in the shade, skin protection, wearing a hat, maybe wearing long sleeves if possible, using sunscreen. There's usually 87,000 new cases per year. The UV radiation causes damage to DNA in the skin, which causes a mutation. So remember, we talked way back in the cell proliferation stage where the mutation begins. This would begin with the UV radiation. It mutates the cell and it causes melanoma. So again, definitely more of a high risk in fair skin, freckles, and a skin biopsy is usually critical in diagnosis. So this type of tumor arises from melanocytes, so it's cells that make melanin. It causes most skin cancer deaths, which is melanoma, and it has such a high rate of metastasis. This is why this cancer is so deadly. So usually it can metastasize to the brain and the heart, are very typical for melanoma. UV radiation is the main cause, or family history. It typically occurs in the lower legs of women and in the trunk and the head of men. This type of skin cancer is irregular in color, surface, and border. The colors tend to be red, white, blue, black, gray, and brown. I like this slide a lot. It gives us the ABCDEs of melanoma. So it's what we really need to assess and look for if we're trying to find melanoma. So A is asymmetry. So one half of the mole does not match the other. So if you were to split that right down the middle and you fold it in half, it will not match. B is border. So the edges would be irregular, jagged, notched, an irregular, benign mole. It should be rounded or oval. Then we go to C. We want to look at color. So we just said red, white, blue, black, gray, and brown. That's very typical for the colors of melanoma. So the color may not be evenly distributed. So that's another thing to look for. So it'll have all kind of different shades of the colors we just talked about. Then there's diameter. So the spot is larger than 1 millimeter across. So the diameter will be large. And then E is evolving. So it's always changing in size. That's another thing to look out for. If the size is always changing, it means it's getting worse and there's something wrong. That's why it's really important if a patient does see a dermatologist, they've been in the sun for quite some time, or they have a family history and they have an ever-changing mole, it's really important to always get that looked at. We need to catch melanoma quickly, get it treated early before it advances because it can spread very quickly through other parts of the body. I like this slide as well. It goes over the 4 different types of melanoma, which I want you to know. So the first one is superficial spreading. This typically begins as a dark spot that is asymmetric, and it has irregular borders or changes color. So kind of what we talked about with the ABCDE. Then there's nodule melanomas. They start as a raised spot and they actually grow vertically. There's acral lentiginous. This appears as a regular growth or a patch, and these are actually on the palms of the hands and soles of the feet. So, and they also change color and size. Then there's lentigo maligna, And this starts as a regularly shaped tan or brown spot. It grows slowly over years. It may become raised or change color. So this is more slow growing melanoma. There's actually two methods to looking at the size of the tumor or the melanoma and actually staging. So there's two methods to determine the thickness of the staging of the tumor. So the first one is Breslow measurement, and that's seen more on the left-hand side of your screen. So it measures the depth of the invasion, the depth of the tumor in millimeters. And then on the right side of your screen, we have the Clark level. So that measures the depth of the invasion of the tumor. So higher the number, the deeper it is. So the treatment actually depends on this. Treatment depends on the thickness of the invasion. If you're at a 0, we can just do surgical incision. It's usually confined to one place without metastasis. So first treatment is excision of the melanoma, but if it has spread to the lymph nodes or the nearby sites, usually chemo and radiation is another option, or even immunotherapy can be utilized. And that is skin cancer. So we're going to move on to cancer of the larynx, cancer of the throat or voice box, really. So those patients who are usually younger than 50 tend to get cancer of the larynx due to the HPV virus, human papilloma virus. Sun can be another common cause, as well as asbestos. Also, if there's been radiation exposure or even poor oral hygiene can be a cause of cancer of the throat. So most laryngeal cancers, they arise from squamous cells that line the mucosal surface of the neck. And what is the major cause? Cancer. Cancer causes 85% of these cancers of the throat. Sometimes even excess alcohol consumption can also be a cause. And like we've said, HPV, sun, asbestos, radiation, poor oral hygiene. Patients may feel a lump in their throat. So these are some symptoms they may feel. So they may feel a lump in the throat. They may have a sore throat that just doesn't go away. They try treatments and it just doesn't get better. Remember earlier we talked about the red or white patches in the mouth. That's a big one for throat cancer, mouth cancer. Even changes in the patient's voice, they develop a hoarseness. Hemoptysis, they start coughing up blood, or they have that constant dry cough. They may have some unintentional weight loss, especially if it's due to symptoms such as a sore throat or swelling. It may hurt to eat and swallow. So we'll notice patients lose weight. Also patients who may have dentures, they have swelling of the jaw, typically in laryngeal cancer, so their dentures may not fit anymore, and that's another sign. An obstructed airway is definitely a late symptom. It means that the tumor is quite large to create an obstruction of the airway, so that's a later stage. Unfortunately, most patients have locally advanced disease by the time of diagnosis, so we typically don't tend to catch cancer of the throat until later. Treatment can be a little bit harsh for patients, especially if it is involving surgery, taking out the voice box. There's a loss of voice. Radiation is very difficult on the neck. It causes, not that great of symptoms, as well as chemo, and we'll get into that. So diagnostics for laryngeal cancer is that H and P. Okay, we really want to do a physical assessment for the ears, nose, throat, mouth, and neck, really making sure that there's no edema or no obstruction in the airway, right? We always want to make sure that the airway is patent. Early detection is really key to survival for these patients. A laryngoscopy can be done. That actually can probably be used to take some biopsies of the mucosal lining, as well as an endoscopy. Again, a biopsy can be done. Chest x-rays, barium swallow, can pick up maybe some swallowing deficits or swelling within the throat. CT or MRI, PET scans. And what can we do to fix this? So surgical interventions surgery is really our first line of treatment options. We really want to get that tumor out. So the first thing that we could do, we're going to talk about least invasive to most invasive. So there's vocal cord stripping. So this is removal of the layers of the tissue in the vocal cords. This actually can be used for biopsy or staging of the cancer. The voice is rarely affected during vocal cord stripping. There may be a little hoarseness after the procedure, but it should not be completely affected. There's also laser surgery. So an endoscope is inserted into the throat with a laser. It's inserted down the throat, and the tumor is actually vaporized by the laser and removed. There's also cordectomy. So that's removal of part or all the vocal cords. Again, the voice may not be totally changed, but there may be some changes in tone, but they typically don't lose all of their voice. If both are removed of the cords, if both sides are removed, then there will be a loss of speech or voice. Then we're talking about a partial or total laryngectomy. So this can be removal of part or the whole larynx, and we're talking about the voice box. And unfortunately, with this, voice production will not be possible with partial or whole removal. Then we talk about pharyngectomy, and that's removal of part or all of the throat itself. So this is actually getting bigger in size. We're not just removing the voice box, we're removing the throat. So with that, we may need to create alternate paths of breathing. So we may need to put in a tracheostomy for the patient to breathe more through their neck than through their mouth. Okay. Then there's lymph node removal. Okay. And then we're going to neck dissection. So these are pretty much the most invasive surgeries a patient can have, radical being the worst. So this is actually removal of all the tissue on the side of the neck, from the mandible to the clavicle. And they're also removing muscles, nerves, and salivary glands. So it's pretty intense. The patient will need a lot of recovery, a lot of emotional support. And then there's the modified radical dissection. This is actually the most common dissection. So typically all lymph nodes are removed. Less of the neck tissue is removed. It can be saved, and nerves are typically spared with the modified radical. And then we go to selective dissection, and this is when actually even fewer lymph nodes are removed. Even less neck tissue is removed, and salivation tissues are typically spared. So this is the least invasive of the dissections. Reconstruction surgery is a big option for patients, especially if they've had more of the radical surgery. That would be an option after removal of the tumors. So how can we manage these patients? So even talking still, radiation therapy may still be an option. Chemotherapy may still be an option. They typically use an external beam for radiation therapy, or internal implants can be done. So again, that's kind of what the seeds, radiation seeds that we talked about before, and placing, it's called brachytherapy. So the radioactive seeds go within the throat. Nutrition therapy is so important, especially because the patient is typically going through symptoms where it's very difficult to swallow, it's painful to swallow. We need to think of foods that are really comfortable and go down easily through the throat. We really need to watch for any aspiration, so making sure the patient sits upright, cutting their food into small bits. We may have to do softer foods like puddings, mashed potatoes, things that aren't too heavy to go down. So risk for aspiration is very high in these patients. Even the liquids may need to be thickened, and the foods may need to be pureed. If the patient cannot swallow at all, we need to think about possible placement of a G-tube, or nutrition therapy will have to go through a tube into the stomach. So they do need to receive nutrition. So that's a really important part of their treatment. Also, if they did lose some speech therapy can be a process as well, in making sure that they have the right therapies for speech. So restoring speech, especially if they've had the surgery where the larynx is removed or the pharynx is removed, we need to really try to get interventions in place where the patient has at least some form of communication. So the first one we talk about is called the electrolarynx. This is a handheld battery-powered device. It creates speech with the use of sound waves. So this is a device that's held against the throat. It does typically allow for speech immediately after surgery. It does have more of a mechanical sound to it. Patients may not like that sound, but this is usually the easiest form of the handheld device. The other option is called a transesophageal puncture, a TEP, and this is actually a one-way prosthetic valve. It's placed in a fistula within the transopharyngeal wall. So the valve actually does two things. It prevents aspiration of food. So if a patient can eat, it will prevent the aspiration. And also if the patient wants to speak, the patient can manually block that fistula or stoma with their finger, and speech can be made by air vibrations. So the air vibrations move against the esophagus and they come out through the mouth. This is more a higher degree of satisfaction for the patients. It's not as mechanical sounding, so the TEP may be more beneficial to some patients who may not like the electrolarynx device. So nursing care, what is most important for the patient? Okay, so remember we talked about nutrition, enteral feeding. That's a big one. If they really can't swallow, we really need to think about the G-tube, enteral feeds, making sure that they get their nutrition. Also providing emotional support. That may not be the patient's preference, but again, just educating them that it's something that they need at this moment. It doesn't, it might not be forever, but it's something that we need to do to make you stronger. Oral hygiene is a big one, especially if they are not eating. They're going to have dry mucous membranes, so swabbing their mouth, brushing their teeth, suctioning their mouth is a big one. Smoking cessation, if we can try to get them to quit smoking, that would be huge. Emotional support, I can't say that enough. Communication techniques. So if they get out of surgery and they don't have a communication device yet, using alphabet boards, writing materials, picture guides, iPads, things to help them communicate. Airway management, it's huge. Watch for swelling, watch for hemorrhaging of the airway. Are they having a lot of secretions that need to be suctioned? Keeping their airway patent is a big one. Wound care, what does their skin look like? How do the incisions look? How's the dressing look? Is there drainage? If they do have a stoma or a trach, providing stoma care. We talked about edema and inflammation of the airway. Hemorrhaging, looking at vital signs. How's their blood pressure? How's their pulse? Are they having a fever? Is there any signs of infection? Making sure they have IV fluids, especially if they're not taking in adequate nutrition. Frequent suctioning, like we talked about. Practicing coughing and deep breathing. We want to limit any pneumonia. Monitor any drains. Look at the color of the drain, of the fluid coming out of the drain. Is the drain patent? Is it kinked? Put the head of the bed up, right? We want that head of the bed as high as we can go. or at the patient's comfort level. We just don't want them lying totally supine. And pain management is a huge one. This next slide talks about leukemia. I wanted to show you guys this video on leukemia. I thought it was very straightforward. It talks to you about the different types of leukemia. I want you to know this video. So just play that within the PowerPoint slides if you can't get to it through this voiceover. But this is the most important slide on leukemia that I would like you to know. In nursing care, so we want to monitor for anemia. We want to monitor for thrombocytopenia, neutropenia, okay? Providing emotional support, treating the side effects of chemotherapy, nausea, vomiting, treating any DIC, tumor lysis syndrome, which we'll go over. So the first thing I want to talk about is thrombocytopenia. So what this is a reduction of platelets below 150,000. It causes prolonged bleeding and spontaneous bleeding without injury. So typically, I mean, if we do have patients who have leukemia, we tend to see bleeding into the skin. So we note that as petechiae. They're usually like small flat microhemorrhages, small flat red bumps with, not bumps, but colors within the skin. They're usually typically red to brown. So when the platelet count is low, red blood cells leak out into blood vessels into the skin, and that is what petechiae is, and that's very common with leukemia. It's common to have mucosal bleeding, nosebleeds, gingival bleeding. The major complication with thrombocytopenia is hemorrhage, and it can be internal or external, so that's why what vital signs are really important. And we know signs and symptoms of blood loss. I know you guys tell me this all the time. Low blood pressure, high pulse, right? So they're tachycardic and they have a really, really soft blood pressure. Also watching platelets for lab values. The patient's symptoms, they may feel weak, faint, dizzy. So this is a picture of petechiae. So we do want to do a H&P, get a history and physical. A bone marrow aspiration. The patient may need a bone marrow aspiration to test CBC, platelet count. For treatment, we may need to do platelet transfusions. Corticosteroids are very common, and rituximab is a medication. So for nursing, we want to discourage any use of aspirin or medications that reduce platelet adhesiveness. We want to observe for signs of bleeding. We want to use small gauge needles and try to avoid IM injections if possible, and monitor labs. So if you think about what we just talked about with, remember we talked about Plavix and heparin in our last content. It's very similar to treatment like that. So, stool softeners, you don't want the patient to strain. We don't want to vigorously brush our teeth, vigorously blow our nose. Shaving, we need to watch for shaving. So always giving that type of education to patients. Next, we just want to talk about neutropenia. So this is a reduction in neutrophils. So what we do is we actually take the absolute neutrophil count and we multiply it by the total number of white blood cells, and that's the percentage of neutrophils. Any reduction in neutrophils, anything to watch out for will be less than 1,000 cells, and in a severe neutropenia will be less than 500 cells. Chemotherapy and any immunosuppressive therapy is the most common cause. And the lowest point of neutropenia is actually called nadir. These patients are really predisposed to infections. So their normal fighter response, which is the phagocytic mechanism in the cells, is impaired, and it's not going to fight. It's not going to fight off infections within the patient's body. So their classic inflammation manifestations are really impaired. So we want to watch out for fever. So when a fever occurs in a neutropenic patient, it is assumed to be caused by an infection. Okay, so that requires immediate attention because the body has little or no ability to fight. Minor infections can really lead to severe sepsis and death. So something as simple as a common cold can be detrimental to a patient who is on chemotherapy who is neutropenic. So stat blood cultures are really important, and to get antibiotics started within the first hour is huge. So again, getting a good H&P. What are their white blood cell counts? What are their neutrophils? How's their H&H? We may need to do a bone marrow aspiration, biopsy, chest x-rays. And as nursing, what can we do? We have a big job in this. So we want to identify any infection if present, get those blood cultures stat, start some IV therapy. Do we want to start antibiotic therapy before we get the blood cultures? No, we want to get those cultures first. We want to see what's growing, and then we can start those blood cultures then we can start the antibiotics as soon as we get those blood cultures, okay? But if we start antibiotics before blood cultures, it can affect what may be causing the patient's infection. Washing hands is huge. Patients may need to be, if they're neutropenic, they'll have to be in a single patient room. Limiting any infection to this patient is huge. Isolation precautions. So going in with a mask, gloves, watching visitors, screening visitors. You don't want too many visitors for this patient, especially if they're sick. Neutropenic diet, education on infection and hand washing. And then this last part is tumor lysis syndrome. There's a nice little video on tumor lysis syndrome. So I do want you guys to know this and watch this video as well.